Differential diagnosis: inflammation, acute appendicitis. Etiology of this very common condition is still not clearly known. However, diet, low residual diet, social status, high middle class and upper class residents, European, American, and Australian familial susceptibility, obstruction of the lumen of the appendix with fecal foreign body, roundworm, threadworm, or a stricture, and indiscriminate use of purgatives are all incriminated. Though no age limit is exempt, it is rare before the age of 2 years. It becomes increasingly common during childhood, adolescence, and maximum incidence is noted between 20 and 30 years. Thereafter, the incidence gradually drops. Clinically, two varieties are seen: a non-obstructive type and obstructive type. Non-obstructive variety progresses slowly, whereas obstructive type progresses very fast, and gangrene and perforation are commonly seen in this type. A careful history must be taken if the patient got pain around the umbilicus or in the epigastrium in the beginning, and later on this pain shifts to the right iliac fossa. He is undoubtedly suffering from an acute appendicitis. The initial pain is visceral and felt on the midline irrespective of the position of the appendix, since developmentally the midgut from which the appendix develops is a median organ. Second pain is due to irritation of the parietal peritoneum lying in close proximity to the appendix. Therefore, it depends on the position of the appendix. The pain is dull-aching in character in obstructive type of appendicitis, whereas this is of colicky nature in obstructive appendicitis. Pain is followed by nausea, vomiting, along with anorexia depending on the degree of distension of the appendix. Fever is almost always associated with these conditions. The sequence of symptoms of pain, vomiting, temperature is known as the Murphy's syndrome. So far as the bowel habits is concerned, constipation is usually accompanied, but there may be diarrhea in case of acute pelvic appendicitis or with appendicular abscess. Examination reveals presence of hyperesthesia in the sternus triangle, tenderness at the McBurney's point, muscular grating, rebound tenderness over the appendix. Positive Rousing sign in definite diagnostic clue should always be looked for. Within 2 or 3 days, a tender and fixed lump develops at the side of the appendix, which is known as the appendicular lump. Sluggish peritoneal sound on the right iliac fossa is also evident in auscultation. Should perforation take place, the outlook temporarily improves with the disappearance of the pain, but very soon the feature of spreading peritonitis appears. Pain is complained of all over the abdomen. Vomiting may become more marked, but more important is the pulse rate, which gradually rises and the temperature becomes subnormal. Restricted movement of the abdominal wall, board-like rigidity, spreads of tenderness from the right iliac fossa to the left iliac fossa, and silent abdomen on auscultation leave no doubt that peritonitis is spreading. In estimating the degree of spread, the pulse rate is an important guide. Variation of clinical features are observed according to the nature of the disease, the position of the appendix, and the gaze of the patient. Differentiation between the catarrhal and obstructive appendicitis. In catarrhal appendicitis, the onset is gradual. The pain is dull-aching, and the patient carries on her usual duties, but with discomfort of the abdomen, nausea, vomiting, and even anorexia. In obstructive appendicitis, the onset is sudden. The patient immediately goes back to her bed with severe colic pain in the abdomen, along with vomiting and the range of the temperature. Retrocecal appendicitis, when the organ is entirely retroperitoneal, there is a hardly any tenderness and rigidity on the anterior abdomen. There may be some tenderness and rigidity in the right flank or more posteriorly. To elicit such tenderness, the patient should be rolled to her left side. If the appendix lies in close relation to the right ureter, the patient may complain of hematuria and pain radiating from the loin to the groin. This confuses the clinician and progresses diagnosis of ureteric stone has been wrongly made. The history of initial pain around the umbilicus, Rousing sign, and psoas test will guide the clinician to diagnosis of appendicitis. Pelvic appendicitis. Tenderness and rigidity may not be prominent on the anterior abdominal wall as in normal. Moreover, the picture becomes more confusing due to the history of diarrhea and range of temperature, irritation of the bladder, strangulary, and rectum, passage of mucus per annum, and tenesmus are also very confusing. Even in this condition, careful history will elicit the pain started around the umbilicus. Presence of Rousing sign and operator test will clinch the diagnosis. Rectal examination is often helpful, as tenderness on the right side of the rectouterine pouch in females and rectovesical pouch in males will give definite clue to the diagnosis. A tender lump or cystic swelling in rectal examination is diagnostic of pelvic abscess. Acute appendicitis in infancy and childhood. The constitutional disturbance are more in children. The temperature is often high along with the pulse rate, vomiting, and diarrhea instead of constipation are the usual features. Elucidation of the tenderness is not so easy as in case of adults. A good technique is to palpate the abdomen with the child's own hand at the point At the point of maximum tenderness, the child will put his hand away. Appendicular lump is rarely seen due to short momentum or poor inflammatory response. For this, early perforation is the rule, and surgeon must diagnose the case very early, perform appendectomy, giving no chance to appendix to perform by itself. Acute appendicitis in elderly. These patients with lax abdominal wall hardly show any rigidity. Moreover, due to atherosclerosis of the appendicular artery, chance of rapid gangrene and subsequent perforation becomes obvious. So, distension of the abdomen in the second stage of peritonitis with constipation and vomiting resemble the picture of intestinal obstruction. The clinician may advise enema enormously to make the patient condition much worse. Acute appendicitis in pregnancy. The enlarging uterus will cause upward displacement of the appendicecum and thus confuses the appendicitis with cholecystitis. Careful history with positive Rovsing sign should help to make the diagnosis. Sometimes can conceal accidental hemorrhage or necrosis of the uterine fibroid may lead to similar pain as in acute appendicitis. With the patient in supine position, the most tender spot is marked with a skin pancet. The patient is now turned to her left and is kept in this position for at least 1 minute. The most tender spot is again found out. If there is shifting of tenderness, it indicates uterine pathology. Pyelitis and cystitis are also common during pregnancy, so one should be careful to consider these considerations in differential diagnosis. Acute cholecystitis. Fatty fertile female of 40 are usually victims. A previous history of fetulum dyspepsia and bleaching, and now with severe pain in the right hypochondriac region radiating to the anterior angle of the right scapula or to the top of the right shoulder are probably indication of this case of acute cholecystitis. Nausea, retching, and vomiting, rise of temperature, and an elevated pulse rate may be associated with this condition. Jaundice may be present in only 1/4 of the cases, maybe due to accompanying cholangitis or due to entry of the bile pigments into the circulation through the damaged gallbladder mucosa. Charcot-Strides, that is pain, jaundice, and rigor due to cholangitis and even septicemia is very characteristic of this condition. Tenderness and rigidity can be elicited on the gallbladder point. Gallbladder is hardly palpable, so if so, it is due to the organ being wrapped with greater momentum. Overlying rigidity stands in the way of better palpation. Very rarely, an empyema of the gallbladder may become palpable if the clinician becomes very gentle. In special investigations, blood examination is helpful, as in 85% of the cases there is elevation of the WBC count. In half of the patient, there is rise in serum bilirubin, and 1/3 of the cases serum amylase will be increased. Oil cholecystography is contraindicated. Ultrasound and radioactive scanning are helpful in diagnosing these conditions. Acute pancreatitis. This condition is commonly seen over 30 years of age. Men slightly dominated over a woman. Pain which felt over the epigastrium is excruciating and agonizing in nature. It is the first in severity considering all abdominal cases. It tends to pierce the back or to the left loin, which becomes more severe when the patient lies down. So the patient shows a tendency towards sitting on the bed, leaning forward. The patient is constant in nature. The pain is constant in nature and not colicky. Vomiting is profuse, projectile, and follows pain. Pulse rate is almost always quickened with the commencement of the disease. Shock and cyanosis are the two distinct features of these conditions. Trauma is due to the absorption of the incompletely split products of protein and later to toxemia and anorexia caused by diminished excretion of diaphragm resulting from the inflamed pancreas. Temperature is at first subnormal and does not rise over normal limit on the first day of the disease. While tenderness is very obvious just above the umbilicus, muscle guard is conspicuous by its absence. In acute pancreatitis, the left costovertebral angle may be tender due to inflammation of the tail of the pancreas. In late cases, muscular rigidity may be present to confuse this condition with peptic perforation. There may be some fullness of the epigastrium, discoloration of the loin, grey turner, and around the umbilicus colon sign are the late features of this condition. Special investigation estimation of the serum amylase is the most widely used test. A serum level of more than 400 homogeneous units is suggestive where as more than 1,000 homogeneous units is almost diagnostic. UNA analysis will also be increased in this. UNA amylase will also be increased in these conditions. Recently, elevation in the serum and the UNA lipase have been given importance, but subject to limitations. Parasynthesis fluid is analyzed, and both amylase and lipase levels are raised. State X-ray findings have been discussed in the section of special investigations, but the presence of a sentinel loop and a single dilated ethonic loop of small bowel is contributory evidence for this diagnosis. In ultrasonography and CT scan, one may detect edematous pancreas, but the images are poor in the obese. Acute colonic diverticulitis. This condition mainly affects the pelvic organ. Typically, the pain is complained of in the left iliac fossa. Tender, thick pelvic colon can be palpated in the left side of the abdomen. abdomen, perforation is not very common. More common is the localized peridiabetic abscess. In this condition, the pus is confined, the mesocolon is greatly thickened, and the bowel becomes swollen and edematous. Intestinal obstruction may result from thickened colon. Muscular rigidity is always present in this condition. Occasionally, localized abscess may burst to the exterior, forming external fistula, or into any viscous urinary bladder, forming intestinal fistula. Very rarely, carcinoma may supervene. Sigmoidoscopy and barium X-ray are helpful in diagnosing this condition. Acute regional iritis. This condition may resembles acute appendicitis. Pain in the right leg fossa is common in both these conditions, but in this condition, there may be a long previous history of intestinal colic due to intestinal obstruction, which is a feature of this condition and never found on appendicitis. And diarrhea, it is again particular to this condition and never seen on appendicitis before the onset of the attack. A tender mass may be felt in the right iliac fossa and will be felt by pelvic examination. A patient when complains of pain in the right leg fossa along with certain other complications like anal fissure, fistula, or edematous skin tag, the diagnosis becomes certain. If an appendicular lump does not resolve by medical treatment, one should think of 4 conditions, of which the first is the Crohn's disease, the second is the ileocolchical tuberculosis, and the third is the actinomycosis, and last, though rare, is a carcinoma. After appendectomy, sinus complicates, one should think of possibility of Crohn's disease. Acute salpingitis. Usually the disease starts at a time of menstruation or during the first week after abortion or delivery. The pain of acute salpingitis is mainly felt on the side of the hypogastrium or even in the iliac fossa. So to differentiate from acute appendicitis, one should carefully take the menstrual history and ask where did the pain start. Normally in appendicitis the pain starts around the umbilicus and then shift to the right iliac fossa, whereas in this condition pain remains static in the iliac fossa. The temperature usually rises from 102 degrees Fahrenheit or even more. Difficulty in micturition, example scalding pain during micturition, is a common accompaniment of the condition. Abdominal rigidity is also not so pronounced as in appendicitis. Vaginal discharge is again a pathognomic feature of this condition. It may be a recent onset or an exacerbation of the long-standing discharge. Vaginal examination will reveal a somewhat enlarged uterus when this condition has occurred following abortion or peritoneum. The cervix may be softer but will cause tremendous pain if it is moved. Only when the acute stage is over and unilateral or bilateral swollen tubes may be discovered. Acute non-specific mesenteric lymphadenitis. This is mainly a disease of children below 6 years of age. After 14 years, it is better not to make this diagnosis. This condition mainly completes with acute appendicitis. The pain starts around umbilicus. The pain may be of colic in nature. Vomiting is usual and occurs in the beginning of the attack. The temperature may be raised just above normal. There is hardly any difference in pulse rate, which is again a differentiating point against acute appendicitis. The patient indicates that the site of pain or diffuse area above and medial to the position of the appendix. The site of pain remains constant without showing any tendency to shift. The clinical feature of pain in appendicitis. On examination, too much rigidity is never present. If one becomes gentle in palpation, one may feel enlarged lymph nodes on the palpation. Shifting tenderness, clean sign, is a pathognomic feature of this condition. After locating the area tenderness in the supine position, the patient is rolled to the left side and kept in this place for a few minutes. Tenderness moved to the left. This is a distinguishing feature from acute appendicitis, where tenderness is relatively fixed. Of course, the students should remember Makers diverticulitis, which shows similar type of shifting tenderness. Acute ulcerative colitis. Ulcerative colitis is mainly a chronic condition characterized by relapse and remissions. Only 5% of cases it may present as an acute condition and deserve mention in this chapter. Instant diarrhea containing blood, mucus, and pulse, high rise of temperature, and toxic states are main features of this acute condition. When the whole or a substantial portion of the colon is involved, the attack is likely to be more severe with some systemic upset. The depth of the ulcer also an important feature in this aspect. Deep ulceration extending up to the deep muscular layer will cause toxic colitis with severe systemic manifestations. Severe abdominal distension may occur from toxic megacolon. Depletion of the protein with low serum albumin and loss of body weight also accompany this condition. Erythema nodosum, pyoderma, arthritis, etc. are the complications of systemic involvement. It must be remembered that colitis in the early is much more dangerous than in young patients. Elderly is much more dangerous than the young patients. Straight X-ray, endoscopy, and rectal biopsy will cleanse the diagnosis. Subdiaphragmatic subphrenic abscess. This condition usually follows some intraperitoneal lesion Example: perforated peptic ulcer, abdominal trauma, acute appendicitis, operation on biliary, operation on the stomach. The patient usually runs temperature without any definite cause. Pulse rate and the rate of respiration also goes up. Pain, if complained of, helps in diagnosis. It is usually felt over the abscess in the hypochondriac region. Pain may be referred to the corresponding shoulder due to irritation of the diaphragm. On examination, careful palpation may elicit an area of tenderness over the abscess. It must be confessed that there is hardly any definite diagnostic feature of this condition. Suspicion is the main help to diagnosis. Popular aphorism that signs of pus somewhere, signs of pus nowhere else, signs of pus there, still to be remembered. Sluggish or no diaphragmatic movement in X-ray screening and elevation of the diaphragm on that side are diagnostic evidence. Amoebic liver abscess. It is not an uncommon condition to cause acute abdomen in tropical countries. Adult males are usual sufferers. It is a complication of amoebic dysentery. The patient presents with acute pain in the right hypochondriac or epigastric region, which is increased by alcohol, walking, riding a vehicle, and a jarring. The patient often supports the upper right side of the abdomen with his hands when he experiences jarring or vibration. Such pain is often associated with pyrexia, rigors, and profuse sweating at night. On examination, a swelling may be detected in the right hypochondriac or epigastric region, which is extremely tender, moves with respiration, and otherwise immobile. Aspiration reveals chocolate colored pus, anchovy sauce. Radioisotope liver scan, CT scan, sigmoidoscopy, and barium NMR X-ray will reveal the diagnosis. Complications are rupture of the abscess into peritoneal cavity, giving rise to acute peritonitis with board-like rigidity, pleural cavity, empyema into the lung, chocolate-colored pus is expectorated or into the intestines. Perforation, peptic perforation. The clinical picture is described in 3 stages. The first stage is known as the peritonism, that is irritation of the peritoneum. It is due to the leakage of the gastric juice into the peritoneal cavity, chemical peritonitis. This stage usually lasts for about 6 hours. Usually an adult male who gives a previous history of peptic ulcer is suddenly seized with acute burning pain over the epicastrum. The patient may be referred to the pain may be referred to the tip of the right shoulder due to the irritation of the undersurface of the diaphragm. The pain may gradually gravitate down along the parabolic gutter to the right area fossa. At this stage, one may misunderstand the pain to be due to acute appendicitis. The patient may or may not vomit. On examination, there will be little change in the pulse, respiration, and temperature. Tenderness and muscle guarding are constantly present over the site of perforation, that is upper half of the right rectus muscles. Great importance should be laid on the diagnosis of this condition at this stage, as chance of survival of the patient gradually declines with passage of time. Diagnosis in the first stage mainly rests on 2 features: vice onset of the pain with a dramatic suddenness in the patient who has given a previous history of peptic ulcer, and muscle guard over the upper half of the right rectus muscle. In the late phase of this stage, pain may be felt on the right iliac fossa, which adds confusion to the diagnosis. The second stage is known as the stage of reaction. The irritant fluid becomes diluted with the peritoneal exudate. The intensity of the symptoms dwindles, although the fire is still burning under the ashes. The patient feels comfortable, and nothing is more deplorable than the attending doctor sharing the patient's comfort. Symptoms are no doubt relieved, but signs are there and should be looked for. Muscular rigidity continues to be present. The other 2 new features are obliteration of the liver dullness and shifting dullness. Rectal examination may elicit tenderness in the rectovesical or rectorenal pouch. Straight X-ray in sitting position will show air under the diaphragm in 70% of the cases. The third or the final stage is the stage of diffuse peritonitis, and it indicates that the patient has gone into the step further towards the grave. The pinched and anxious face, shrunken eyes, and hollow cheeks. The so-called facies hypocritica, with rising pulse rate which is low in volume and tension, persisting vomiting, board-like rigidity of the abdomen, increasing distension of the abdomen, all give hint to the diagnosis of this condition and imminent death. Perforation of the typhoid ulcer. This usually takes place in the 3rd or 4th week of the typhoid fever. Hemorrhage also occurs in this period. Sudden collapse, fast steady pulse, abnormal temperature indicates either perforation of the hemorrhage, but a history of sudden pain, definitive tenderness and rigidity, however slight it may be, will lead to the diagnosis towards perforation. The liver dullness will be obliterated and the shifting dullness test may be positive. Perforation of the ulcerative colitis. In 4% of the cases, ulcerative colitis perforation may complicate the fermenting types of the disease. It is usually preceded by toxic megacolon. Sudden pain in the abdomen with distension of the shock should immediately raise the suspicion of this condition. Fecal contamination of peritoneum is more dangerous and should be operated on immediately. Perforation of the diverticular diseases of colon. Generalized peritonitis from perforation is extremely rare. More often a localized abscess results. If general peritonitis takes place, mortality rate is very high and it is not less than 50%. Acute intestinal obstruction. The mortality rate from acute intestinal obstruction give rise with each passing hour from the onset of the disease. So early diagnosis is imperative. The three main clinical manifestations of acute intestinal obstruction are clinical colic, intestinal colic, vomiting, and distension. The absolute constipation, which was also considered to be one of the cardinal features, should be excluded as it takes no less than 24 hours to develop these symptoms. Intestinal colic, when the obstruction lies in the jejunum or high in the ileum, the colic appears in waves at intervals of 3 to 5 minutes. The pain lasts for about 30 seconds. This interval becomes longer in obstruction of the terminal ileum, where it is about 8 to 10 minutes. The site of pain will give an indication as to the site of obstruction. Example, small intestinal cramps are referred to the epigastrium or umbilical region, whereas the colonic cramps are to the lower abdomen. Hypogastrium, vomiting. This is a fairly constant symptoms. The frequency of vomiting depends on the site of the obstruction. The upper small bowel obstruction vomiting is much more frequent than obstruction in the terminal part of the small bowel. At first, the vomitus is in the is the gastric content, that is ingested food particles and fluid. Next, it is the content of the duodenum, which is predominantly bile, and lastly last is the content of the small intestine above the site of obstruction. Virtually, it takes about 3 to 4 days in complete intestinal obstruction to vomit before vomiting become feculent. This is a grave sign and should be diagnosed long before this distension. It must be confessed that this may not be very early sign, but an experienced clinician distension may be evident in early stage and is considered to be diagnostic feature. Absolute constipation. It must be remembered that absence of history of recent constipation should under no circumstances exclude the diagnosis of intestinal obstruction. The patient might have moved his bowel in the morning. The symptoms started in the afternoon for constipation to arrive as a significant sign. One has to wait for another 24 hours. This only makes the diagnosis late in case one includes constipation to be one of the 4 major signs of this condition. Again, absolute constipation appears later in the process, as it means failure of passage of both feces and flatus. To add to more confusion, intestinal obstruction may be accompanied by diarrhea, mesenteric vascular occlusion, Richter hernia, and a pelvic abscess associated with obstruction by adhesion, which will produce diarrhea instead of constipation. Dehydration. The higher is the obstruction, more will be the dehydration due to tenderness or tremendous loss of water and electrolytes. To the contrary, obstruction of the terminal ileum is associated with relatively small amount of loss of fluid and electrolyte, as the secretions of the GI tract are reabsorbent. As a matter of the fact, dehydration appears late in obstruction of the terminal ileum, but distension becomes pronounced, where in obstruction of the jejunum, dehydration appears earlier, but distension is much less. On examination, the patient looks anxious and restless. In the early stage, pulse, respiration, and temperature show no deviation from the normal. Inspection rarely shows distension of the distension in an early stage, but a little fullness cannot be missed by an experienced clinician. Distension either central small gut obstruction or peripheral large gut obstruction or regional volvulus of sigmoid colon or cecum is a distinctive feature in acute intestinal obstruction. If the clinician becomes more patient and watchful, he can discover visible peristalsis, which is again diagnostic. Gentle flickering of the abdominal wall may initiate visible peristalsis. It can be overemphasized at this stage of inspection to inspect all the hernial sites, particularly inguinal, femoral, and umbilical. While umbilical hernia becomes obvious on inspection, inguinal and more often femoral hernia are missed if these sites are not looked for. On palpation, muscle guarding is conspicuous by its absence. If the hand is laid flat upon the abdomen, the underlying coils of intestine may be felt to harden and soften alternately. During palpation, one must be careful to discover a lump, as it may be found in intussusception neoplasm of the small or large intestine, or an interabdominal abscess. Presence of muscle rigidity and rebound tenderness suggests internal strangulation. Percussion is not much informative in this sense that it only reveals resonant note of gaseous distension of the bowel. Auscultation is quite an important procedure, yet often missed. Presence of borborygmy, which coincides with the intestinal colic, is very diagnostic. In case of intestinal obstruction, silent abdomen suggests paralytic ileus. Localized absence of intestinal sounds means localized peritonitis or internal strangulation. Rectal examination is very usually non-informative, yet ballooning of the rectum is particularly noticed. Very occasionally, one may detect pelvic abscess, a lump caused by intussusception or neoplasm of the small or large intestine. Straight X-ray of the abdomen is very diagnostic. It shows gas distended lobes of the intestine and multiple fluid levels. Gas distended bowels are seen earlier, and for Fluid levels to appear in the fluid must be separated from the gas. Jejunum, ileum, and colon may be seen distended with gas and will show characteristic appearance in the X-ray. Jejunum is characterized by its valvular convolutions, which are placed at regular intervals, giving rise to concertina effect. Ileum is characterized by straight lines of its walls. Large intestine shows ostration folds, which leaves indentations in the walls, while a gas shadow can be seen even in the supine position. Fluid levels are seen only in erect posture. The number of fluid levels is proportionate to the degree of obstruction and to each site. Number of fluid level is more, and the nearer the obstruction is to the ileocecal valve. In paralytic ileus, fluid level becomes more conspicuous and more numerous. In obstruction of the large intestine, a gas field becomes obvious in X-ray. In this context, one should remember two fallacies. In infants under the age of 2 years, after few fluid levels in the small intestine are not abnormal. Two inconsistent fluid levels may be seen in duodenal cap and at the terminal ileum. Having diagnosed that the case is one of acute intestinal obstruction, the clinician should proceed to detect the site, the nature, and the cause of the obstruction. The site of obstruction: the high intestinal obstruction, vomiting is early and profuse. The vomitus consists of gastric fluid beginning and bile later on. Fecal vomiting is never present. The patient becomes dehydrated very soon. The urine is scanty, though distension is not a marked feature, yet fullness of the epigastrium is often noticed. In this category, acute dilatation of the stomach and the pyloric stenosis may be included. In low and small intestinal obstruction, the onset is sudden. The pain is situated over the umbilical region. The vomiting is present, but it is neither early nor profuse. In early stage, the vomitus consists of gastric content. Later on, bile becomes feculent in the last stage. Distension is marked and is central visible peristalsis in the form of ladder pattern is often noticed. In large gut obstruction, the patient is usually elderly. The onset is gradual, so it is often said to be chronic. The pain is not very prominent. If present, it is complaint of in the hypogastrium. Vomiting is a very late feature and it may not be present altogether. Distension is more marked on the flanks. Careful palpation of the iliac fossa may reveal cecum to be distended and may harden under the examining finger. Rectal examination may reveal an annular growth. Nature of the obstruction: intestinal obstruction may be simple or strangulated and dynamic or paralytic. In simple obstruction, there will be intestinal colic. Pulse, respiration, temperature, and blood pressure remain unaffected. On palpation, muscle rigidity, rebound tenderness, and are conspicuous by their absence. In strangulation, however, there is no complete remission of the pain between colics, so colicky pain of simple obstruction is replaced by continuous pain. Pulse becomes rapid, temperature may be elevated, there may be tachypnea, blood pressure falls from the beginning, presence of muscle rigidity and rebound tenderness immediately making the diagnosis. 2 hours gastric suction if failed to relieve pain indicates internal strangulation. Though external strangulation is easier to diagnose by tense, tender and irreducible swelling without any impulse on coughing, yet internal strangulation is not so easy to diagnose and must be looked for. Paralytic ileus may occur in the early postoperative period after an abdominal operation or as a complication of diffuse peritonitis. It is differentiated from dynamic intestinal obstruction by the following points. History of abdominal operation or features of peritonitis are absent. Gradual distension of the abdomen without visible peristalsis. Absence of colic pain. Silent abdomen in auscultation. Cause of obstruction. In determining the cause of obstruction, age of the patient should be taken into consideration first. In newborn, the cause of obstruction is congenital malformation, that is congenital atresia of the esophagus, congenital pyloric stenosis, meconium ileus, congenital atresia of the duodenum or the ileum, Hispung disease, etc. In infancy, endosusception is endosusception and obstruction due to worms. In adolescent, besides endosusception, bands or adhesions resulting from Meckel's diverticulum or local peritonitis due to appendicitis, tubercular peritonitis, Jebs mesenterica, etc. In adults, obstruction by a band volvulus growth should be considered, whereas in old, carcinoma of the colon is the usual cause. A fatty woman of 40 with previous history of cholelithiasis, if present with intestinal obstruction, possibly of cholestasis, should be considered. A strangulated hernia may occur at any age. Acute intestinal obstruction, usually the patient is lusty male baby between 6 to 12 months of age. The onset is usually sudden. The child screams in abdominal pain, draw his legs up. The attacks usually last for a few minutes and came back within 15 minutes. In between the attacks, the patient looks somewhat drawn. Facial pallor is an important sign which always associated with each attack. Vomiting is more often late to come, usually takes about 24 hours. Slight rise of temperature may be seen even during the first 24 hours. Absence of distension with severe colic in the abdomen pallor should give the suggestion towards the diagnosis. Absolute constipation is rarely seen. In the early stage, normal stool are passed frequently. Later on, blood and the mucus are evacuated, which is popularly known as red currant jelly. On examination, the abdomen is hardly distended. The main diagnostic feature is a palpation of the lump, which is curved, sausage-shaped, and the line of the colon with its convexity towards the umbilicus. Should the lump harden under the examining fingers asynchronously with the attacks of the screaming, the diagnosis is established. The lump may not be felt when it is lying just under the right or the left costal margin. The examination must be gently conducted, as contraction of the abdominal muscle may stand in the way of the good palpation of the lump. A feeling of emptiness in the right iliac fossa is known as the signed dance. Too much stress should not be paid on this sign. When everything has been made ready for operation, it is a good practice to search for the lump under general anesthesia. On rectal examination, blood-stained mucus will be found on examining finger. There is absolutely no fecal odor. If intussusception has traveled far enough, the apex may be felt per rectum and will be felt like cervix uteri. In very rare instances, intussusception may project through the anus. This indicates that a patient possesses a long mesentery and render the small intestine unduly mobile. After 6 hours, sign of dehydration will appear. After 24 hours, the abdomen will start distending and the vomiting become profuse. X-ray is confirmatory. Straight X-ray of the abdomen will reveal increased gas cirrhosis in the small intestine and absence of cecal gas cirrhosis. Barium enema X-ray in the presence of ileocolic intussusception shows the typical pincher-like ending of the barium enema. Of course, in ileocecal interception, barium enema X-ray will not be helpful if the ileocecal valve is competent. Volvulus of the sigmoid colon. Usually middle-aged or elderly males are sufferers. The onset is sudden with acute pain on the left side of the abdomen. Abdominal distension soon follows, and in no other condition abdominal distension becomes so severe. Constipation is usually absolute, but occasionally large quantities of flatus and feces may be voided due to untwist of the bowel. A straight X-ray is confirmatory and it shows enormous distension of the sigmoid colon with gas. Volvulus of the cecum. While volvulus of the sigmoid colon may affect middle-aged and elderly, this condition is more common in young individuals between 20 and 30 years of age. This condition only occurs when the right half of the colon is laxed and mobile. Distension mainly prevails right lower abdomen, which gradually involves the whole of the abdomen. Picture becomes very much similar to low small bowel obstruction. Straight X-ray will show a large gas-filled cecum and later on lobes of gas-filled ileum. Meconium ileus. 5% to 10% of infants born with fibrocystic disease of the pancreas will have small bowel obstruction due to abnormal incipient meconium resulting from the inadequate secretion of the enzymes from the pancreas and intestinal mucosa. Family history is often noticed. The infant is born with intestinal obstruction. The typical radiograph shows distended lobes of small intestine. There is scarcity or absence of fluid levels in the upright film. Air comes down the small intestine into the thick meconium, causing a soap bubble or ground glass appearance. Volvulus of the midgut. Volvulus neonotorum. Arrested rotation of the gut is responsible for this condition. Floating cecum together with whole of the intestine floats on a narrow stalk of mesentery. The child presents the symptoms of intestinal obstruction immediately after birth. The classical features of radiological findings are similar to any small bowel obstruction. Appearance of dehydration is very fast and treatment should be commenced as quickly as possible. Ghost on ileus. Obese women with 40 to 50 years of age are usually the victims. Often the previous history of cholelithiasis can be obtained. The site of impact is about 2 feet proximal to the ileocecal valve. This is the narrowest part of the small intestine. Symptoms are often elusive. Recurrent mild colics accompanied by vomiting is the usual presenting symptom. In majority of cases, the obstruction is incomplete, so there will be some result from enema. Abdominal distension is a late feature. Straight X-ray may reveal the stone to confirm the diagnosis, but even if it may not be present, gas distended lobes of ileum should not be missed. Mesenteric vascular obstruction. This condition occurs in those who are known to be suffering from cardiac valvular disease or atherosclerosis. Pronounced shock, colic pain, which is quite severe, distension and frequent vomiting are usual symptoms which may mimic acute appendicitis. Hematomesis and melena occur in about about third of the cases. On examination, localized rigidity and tenderness over the infracted area can be elicited. The symptom and sign just described are features of mesenteric arterial occlusion. Mesenteric venous occlusion shows different types of clinical features, and intra-abdominal obstruction or portal hypertension may predispose this condition. Intestinal obstruction due to worms. Usually, children below 10 years of age in tropical countries are the victims. Aggregation of ascites, excursus lumbricus obstructs the lumen of the lumen of the distal small bowel. On examination, the child is very much undernourished. He gave history of vomiting and a worm or of taking antihelmintic. A swelling may be palpable in the right iliac fossa which speeds on pressure. This is the condition. If this condition is suspected, the stool is examined, blood is examined for eosinophilia. Straight X-ray may reveal the worms in the gas-filled loops of intestine. The only complication of significance is perforation peritonitis, in which the worms penetrate the intestinal wall. Bolus obstruction. This occurs when insufficiently masticated food obstructs the lumen of the distal small bowel. Narrowest portion of the intestine is about 2 feet proximal to the ileocecal valve. This only occurs after partial gastrectomy, as normally these foods are retained in the stomach until they are partially digested. Dried fruit, coconut, unmasticated orange pulp usually cause this type of intestinal obstruction by forming bolus. Hemorrhage and torsion. Ruptured ectopic gestation. Sudden onset of acute pain over the epigastrium with tremendous shock in omen of childbearing age having history of 1 or 2 missed periods is suggestive of this condition. Pain is often severe and mainly located in the hypogastrium with radiation backwards and downwards. Gradually, the pain may be involved whole of the abdomen and even to the tip of the shoulder due to irritation of the undersurface of the diaphragm by a sanguineous fluid. When hemorrhage is considerable and the foot of the bed is raised to combat shock, the examination there may be slight distension of the abdomen due to meteorism. Blue discoloration of the umbilical region, though very rarely is distinguishable sign of this condition. Palpation will reveal deep tenderness in the hypogastrium. Rigidity is not that pronounced as inflammatory conditions. Rebound tenderness will be positive at an early stage. Shifting dullness will be positive when there is sufficient fluid blood in the peritoneal cavity. Vaginal examination is important and may be diagnostic that the cervix feels softer than normal. All the fornices are tender in acute appendicitis. Only the right fornix and in case of pelvic abscess, posterior fornix will be tender. And the gentle movement of the cervix will cause tremendous pain. Give enough indications of the diagnosis of these conditions. Later on, restlessness, air hunger, increasing pallor, and running steady pulse will leave no doubt about diagnosis. Ruptured uterine cyst, follicular cyst. If a young woman presents with a lower abdominal pain in the middle of her menstrual period, this condition should be suspected. When this problem affects the right side, it may mimic acute appendicitis. So that history of last menstrual period is very important and must always be asked. That the pain commences in the right iliac fossa and not that it started in the umbilical or epigastric region and then shift to the right iliac fossa is very much suggestive of this condition. Last menstrual period is also very important to exclude ruptured ectopic gestation in exceptional cases of intraperitoneal hemorrhage is considerable to make the shifting dullness test positive. Twisted ovarian cyst. If a woman be seized with colic abdominal pain with vomiting at frequent intervals, this condition should be thought of. If a lump is present which is dense, tender, and cystic with definite smooth margin involving the lower abdomen, if it is a twisted ovarian cyst. Underlying rigidity may mask the lump. If it be small enough to be situated entirely within the pelvis, the lump will not be palpable abdominally. Vaginal examination in this case may be helpful. The history that the lump was present before will clinch the diagnosis. Rupture or leaking of aneurysm. When the patient, usually middle-aged or elderly male, presents with a severe upper abdominal or lower chest pain and marked shock, a few conditions should come in mind as probable diagnosis. These are perforated peptic ulcer, coronary thrombosis, acute pancreatitis, rupture or leaking aortic aneurysm. The patient with this condition is often non-hypertensive patient, but when leakage starts, the blood pressure falls catastrophically. He usually complains of severe upper or central abdominal pain radiating through the back. Clinical features of acute pancreatitis. On examination, if the patient is considerably anemic, the aneurysm may be palpable if the leakage has not been much or not ruptured. If the leakage has started or there will be rigidity of the central abdomen, more so a little to the left. A mass blood clot may be felt in the left iliac fossa resembling called pericolic abscess in diverticulitis of the sigmoid colon. Arterial pulses of the lower abdomen are feeble or absent. Aortic dissecting aneurysm. Dissection usually starts in the aortic arch. Hypertension is often the high degree to cause this condition. Patient is excruciating, starts in the retrosternal region, radiation between the shoulders or the back or shoulders to the back, and also space to the upper abdomen as dissection proceeds downwards. Signs of shock are apparent, but the blood pressure may be brought down to normal level in an otherwise highly hypertensive patient. Nothing very specific can be discovered on abdominal examination. There may be inequality of pulses of superior and inferior extremities as the dissection progresses. Ultimately, there may be discrepancies of pulses of one extremity or the other. Colic. The common features of colics are sudden appearance of gripping pain which stay for period during which the patient almost tosses on the bed, then passes off as suddenly as it came. Nausea, vomiting, belching, retching, etc. Varying degree of collapse, absence of muscle guard, voluntary contraction of the abdominal wall may be mistaken for muscle guard. Biliary colic. Severe colic pain over the right hypochondrium radiating to the inferior angle of the right scapula and right shoulder is a biliary colic. It is also called gallstone colic as it is caused by spasm of the gallbladder to force the stone down the cystic duct. Tenderness over the gallbladder region. Jaundice may or may not be associated with depending on whether the stone is in the common bile duct or in the cystic duct. The pain is called a colic as it is intermittent, but the patient seldom describes it as a gripping pain. The common bile duct very little smooth muscle. Common bile duct has very little smooth muscle in its wall, and this probably cannot be a source of severe colic pain. Aortic colic. Typically, the patient is seized with sudden pain starting in the loin and radiating down to the testis, groin, or inner side of the thigh. Distribution of the genitofemoral nerve L1, L2. The testis of the affected side may be drawn up. It is often accompanied by moving and profuse sweating. Tenderness may be elicited over the renal angle. Previous history of similar colic, presence of stones with the urine scarography revealing the stones are confirmatory. Frequency of micturition and strangulation may be present when the stone is impacted at the lower end of the ureter. Hematuria may be associated with this colic occurs when a stone in the renal pelvis temporarily blocks the pelvic extension or enters the uterus to block it. Intestinal colics. This occurs in the small intestinal obstruction, and also in the toxic gastroenteritis. Gastroenteritis occurs due to improper food and must be distinguished from acute intestinal obstruction. History of improper diet occurrence in the other members of the same family having taken the same diet, and the presence of diarrhea will exclude the organic obstruction. In lead colic, occupation of the patient is as a painter. Blue line on the gum, severe constipation are the distinguishing features. Appendicular colic. In obstructive appendicitis, colic pain in the right iliac fossa, vomiting, and the rise of temperature are usual features. It is a far more serious condition than obstructive appendicitis and demands immediate surgical interference due to greater possibility of gangrene and perforation of the appendix, which resulting spreading peritonitis. Extra-abdominal causes. Rupture of the rectus abdominis muscle or tearing of the inferior epigastric artery. This may occur during bout of coughing or in pregnancy during anticoagulant therapy. An extremely tender lump is felt below the arcuate line above the pubic bones where the rectus ruptures. Such tender lump is often diagnosed wrongly as appendicitis when occurs in the right side, but this lump is more medially placed. Bruising of the overlying skin makes the diagnosis of tearing of the inferior epigastric artery certain. If the patient is asked to lift both the legs, keeping the knees straight, the lump becomes more prominent and pain aggravates. Strangulated Spegelian hernia is difficult to differentiate from this condition, but absence of vomiting goes in favor of this condition.